this presentation does take us from the very basics of orthokeratology right the way through to looking at how that can assist us with some myopia control. So let's look at, what does orthokeratology actually mean? Well, we know it's a noun, and it basically means that it's a technique of correcting refractive errors in vision by changing the shape of the cornea with the temporary use of progressively flatter, hard, or in this case, GP contact lenses. Now, it can be used for both myopia and hyperopia, although most commonly it's used for myopia. So let's look at how that works and the origins of being able to flatten the cornea. So there is this myth that back in China, many centuries ago, that the Chinese used to sleep with sandbags on their eyes, and that this sleeping with sandbags on their eyes would flatten their corneas and they would have good vision the following day. Now, we have no firm evidence that this ever happened, but it's something that we definitely hear regularly. But these are the guys that were the true pioneers of orthokeratology as we know it today. So we have Eugene Colt, who was known for his work with the irregular cornea, and actually found that he could flatten a keratoconic cornea really easily with a contact lens, and the patient would see very well. However, I think that's a bit of cheating, because the keratoconic cornea is about 60% softer than the standard cornea. So I think it worked in his favour. The real pioneers back in the day were actually George Jesson and Dr. Newton Wesley. And for those of you who are old enough, and that's not very many of you, you would remember Wesley Jesson contact lenses maybe, or Pilkington Barnes Hines as they became. And it was George Jesson who found that actually by using progressively flatter contact lenses, and this was predominantly during the daytime wear, they could change the corneal shape and they could help with changing the refractive error of myopes. It was Dr. Wesley who actually came up with the idea, or the name, orthokeratology. I think George Jesson came up with something like orthofocus, and Dr. Wesley went, no, we're going to call it orthokeratology. These are some other pioneers. So in the 60s and 70s, after Wesley Jesson, we had Nielsen, Grant, May, Nolan, Ziff and Tab. And again, they were working with PMMA and the early GP lenses. And these were manufactured at that time on what we would class as hand or manual lathes. So it wasn't always very easy on the reproducibility of these lenses, and it wasn't very easy to get things like reverse curves in. So these were just very flat GP lenses. And the same could be said in the late 70s and 80s with Kearns and Binder, although they were starting to look at more advanced and complex lens designs. However, in the 1990s, when we started to use CNC lathing technology, which allowed us to move away from manual lathing and into more complex designs, which could be computerized and were repeatable, we started to look at what we now know as orthokeratology. So these were lenses that could be worn overnight. And this was around the first time these were introduced, and had a bit of an upsurge. And we found that we could put a reverse curve in, and we got some really good stable results with these lenses. So what happens when we put an ortho-K lens on the eye? Well, this is a pictogram that just describes what we do. So we have a standard cornea, and what we do is we fit a relatively flat back optic zone radius in relation to the cornea on the eye. The patient then sleeps in this, and the next morning when they wake up, we have affected some corneal change. We have flattened that central corneal area, and their vision should start to become more normalized or emmetropized. So they become closer to plano than they were. And this, again, I'm talking specifically about myopia. When we talk about hyperopia, it's a different thing altogether. You're not flattening the central cornea, you're causing more of a volcano centrally. Now, there's many ways of describing what we do to that front layer of cells. We talk about corneal bending, we talk about remolding of the anterior corneal layers, You can liken it to hydraulic therapy because we do cause different pressures on the front surface of the eye. We definitely cause central corneal epithelial thinning, and we do cause mid-peripheral thickening of the stroma and epithelial. And just to demonstrate that, here you can see on the left-hand side of the screen, we've got an Ortho-K lens in situ. And then we, again, here on the right-hand side, you can see what's happening. So we cause central positive compression in the central area, which kind of pushes out the epithelial cells and causes negative tension in the periphery. And these cells migrate to this area. As you can see on the left-hand side, you can see this band of fluorescein. That's the reverse curve where these cells get pushed or forced to go into because of this positive compression centrally. But what we should never assume is that we are causing that positive compression by actually touching the central cornea. There is never any central touch. We do not touch the cornea with the lens at all. There is always central clearance, although it's so tiny, it can't be picked up with fluorescein. And again, here we can see that we have in this bottom picture that central thinning of the epithelial cells, and in the periphery where the reverse curve is, you can see that thickening of epithelial cells and stroma. And if you look at the images above of the lens in situ, you can see quite clearly we've created this tear lens diagram, which fits very nicely with where the reverse curve is. So you can see that's where the major amount of tears are situated. But you can also see centrally that we do have this very, very small amount of central clearance. And on average, that's between 10 and 13 microns, which is why we can't pick it up with fluorescein because it's so small. So if we are flattening that central area, my first question to you would be, how is the treatment or correction zone created during that Ortho-K process? So what happens to the cornea to create that treatment or correction zone? Correction zone is because we create this positive tension centrally and then this negative compression. And what we do is we push those central cells out into that reverse curve and we physically reshape the cornea. The force of that migration of epithelial cells into the corneal periphery is what gives us this treatment or corrected zone. Now, there are different types of Ortho-K lenses. Although they all do the same thing, there are different types. What we're going to look at is we're going to look at the most up-to-date generations of these lenses, which tend to be 4 and 5 zone lens designs. So you will find that all Ortho-K lenses will have a back optic zone radius. They will all have a reverse curve. Some have a double reverse curve, but they will all have at least one reverse curve to allow for that migration of cells into the periphery. They will all have an alignment curve. Now, this alignment curve is quite important in very many designs because that's what will give you good centration on your orthokeratology lenses. And with Ortho-K, you need good centration. And you have your peripheral curve. And the peripheral curve is to allow, again, for some tear exchange and good comfort and to allow for easy removal. So let's have a look at how that's made up. So the back optic zone of the lens is quite standard and is between 6 and 8 millimeters. And some Ortho-K designs will allow you to change or alter that. There are some that are very fixed and they won't allow you to change it at all. The radius of the lens is based on the refractive change that is required. The more myopic the patient, the flatter the radius the lens will be. We know that the central tear layer that is created will provide supple applantation force. The back optic zone radius doesn't tend to affect the lens fit. This is all about the size of the treatment zone, and it is almost always spherical. So it's very rare that you will find a back optic zone or a back optic zone radius on an Ortho-K lens that is toric. When we look at our alignment zone on a 4-zone lens, this tends to be 1 to 1.65 millimeters wide. On a 5-zone lens, you have 2 of these. So you have 2 alignment zones, and they will be split on their width to reflect that. And again, this controls the lens movement and centration. So the alignment zone is really important. Now that can be either spherical or aspheric, depending on the lens design. And the sag of that is controlled by either the alignment configuration or a tangent angle. And we'll talk a little bit more about tangent angles and what they are a little bit further on. All of these lenses need a reverse zone or reverse curve, and that allows for this migration of cells. And it joins with the alignment curve normally, and it completes that back surface geometry to allow for the tear reservoir. Again, it can be either spherical or aspheric, depending on the design. And then we have our peripheral zone. So this provides us with the desired edge lift that we require, and it allows for good movement. And again, that important tear exchange, which we need, because we know that that is reduced when we're wearing a lens overnight, when you're asleep. There is very little blink action when you have your eyes shut and you're sleeping. So this allows for slightly better tear exchange. This is just, and I know this is really tiny, so I apologize. This is just a list of the most common Ortho-K lenses available, particularly in the UK. So I'm sure you've heard of things like the Paragon CIT, for example. You may have heard of our own lens, which is the Menicon Z Night. And there are a couple of others. So there's the iDream lens, which is manufactured by Number 7. And I think it's known as something else in the Netherlands and in Europe. We also have something called the Emerald, which is known also as the iGo lens, which is very popular. So this, if you want this chart for any reason, I'm sure that the hosts can make this available to you, and I would be happy to share that with you if it's of use. So please do ask for that if you think it would be useful. Patient selection is really important. I think it's important with any kind of contact lens you're going to fit. And the reason for that is that patients' expectations vary. What patients assume they're going to get out of the lens varies. And we have to be very careful to manage these expectations and choose the patients that we know are going to get the most out of this particular lens type. Because it's very easy, or it can be very easy, to say yes to a patient that maybe isn't suitable. So we have to make sure that we select our Ortho-K patients carefully. Not everybody is suitable for Ortho-K. So the amount of correction that is required will definitely impact how successful the fit is or not. Again, the patient's expectations, and we all know that patients, it doesn't matter how many times we sometimes have conversations with patients about the realities of certain lens designs, sometimes their expectations can be a little bit higher. So we need to be able to manage those well. The age of the patient, and I don't know how you feel about, as individual practitioners, about how young you would fit a patient, for example, into contact lenses generally, or into a contact lens of this modality. But age is certainly a consideration. Patient history is always a consideration. Sometimes an occupation can influence whether you fit Ortho-K or not. So it's possible they may be shift workers. Is that going to influence how well Ortho-K works? Or they may work peculiar hours. And again, if this interrupts certain things like sleep patterns, would that interfere with how well this works? And again, if you combine that with the amount of correction required, if they were somebody who worked nights and needed good vision but were a high myope, is that a good combination? Compliance is also very important. This is a lens that is worn overnight, and we need these patients to be compliant with our instructions, and we need them to have good hygiene. Motivation is also something that we need to look at. So how well motivated is the patient to this kind of modality of lens? And when we talk a little bit later on about myopia control, how well motivated is the patient compared with maybe the parent? So these are all things we need to consider, not just with Ortho-K, but I think in some instances more so. So when we look at the amount of correction required, if you talk to any, I say any, if you talk to most ortho, if you talk to most, yes.
Sorry, we are going to do questions, but
yes,
they will be putting the answers in the chat box.
Okay, so shall I skip straight over the questions?
Yes, please. Thank you.
No, that's fine. Okay, that's fine. So, okay, that's fine. So just very quickly, when we're looking at optimum results with Ortho-K, we would suggest that the maximum correction you really want to deliver is about -450, -5 spherical, with a maximum of about 2.5 diopters with the rule astigmatism. You can correct more than this, but when you go or you exceed this, you will find that you end up with a much, much smaller treatment zone. And that is going to cause, or could potentially cause, issues of glare, flare, and halos. So you need to be very sure about the amount of correction that you can achieve with the particular lens you're using. And some manufacturers will tell you can do more than that. But I think if you want to be a successful Ortho-K fitter, then you're looking at about -450, -5. It can be pushed further than that, and I would never say that you can't get that type of correction, but it depends on how successful you want to be. Okay, so where do you start? So you've got a patient coming in and you want them to be fitted, or they're asking to be fitted with Ortho-K. Well, you probably have everything in your clinic that you need. So you have your slit lamp, your phoropter, or you're able to carry out a refraction. You're able to carry out all of the basic refractive tests that we need to. But there is one thing that is, I believe, pertinent to Ortho-K fitting, something you need that you can't really fit Ortho-K without, and that is corneal topography. Corneal topography will allow you to look at the whole of the corneal landscape, and it will also enable you to rule out any patients that may not be suitable, and it will give you your baseline, and it will tell you how well the treatment of Ortho-K is going. So a corneal topographer, I think, is a must for fitting Ortho-K lenses. You can do it without, but I think it doesn't give you a full picture if you can't see the corneal landscape both before, during, and after. If you don't have a topographer, then these are the kinds of things that you're looking for. So you need a topographer that has a really high degree of accuracy and repeatability. Repeatability, can you hear me? Oh, can you hear me?
Yes,
I can hear
we
you
can
still.
Hear you. Yes, we can.
You can hear me. Okay, where did I lose you?
Yes. Thank you.
Where did I lose you? At the top of the list, or?
Yes, at the top of the list.
Okay, okay. So I apologize. So when you're looking for a topographer, if you don't already have one, the key things are that it's very accurate and repeatable. And some sort of 10 years ago, this was not always the case when you were looking at topographers, but we have some great equipment now available, and they are all very accurate and give repeatable exams time after time. And that's the key with orthokeratology. You need to have something that gives you repeatable data, because those repeated readings of apical radius and eccentricity or elevation are really important. You need a machine that can hopefully give you both axial, tangential, and refractive power curvature maps. And again, I don't know of many topographers that don't give you that level of detail now. The other key thing is that you do need to be able to produce a differential or subtractive map. Now, I know that there's one or two topographers that don't allow you to do that, but this is key, because you need to be able to look at, again, your baseline and where you are today and see where the changes have occurred. Pupil recognition is really useful if that's a facility on your topographer, because that will help to see how well or help you to determine if you have some decentration, will that affect the vision? Does it cross the pupil margin? So having pupil recognition is really important. And you need to be able to see the largest area of the cornea possible with the minimal amount of interpolation. So that means with the limited or the smallest amount of where the topographer is not sure maybe what's going on and is kind of extracting data and creating that peripheral map where it's making assumptions in the periphery. So you need the largest area possible. For those of you who use topography all the time, I apologise if this is not something that's new to you. I tend to find in the UK particularly that we have some practitioners who use topography and love their topographers, but use one map and one map only. And it's never been explained to them the differences between using a tangential map and an axial or refractive map. So a lot of practitioners in the UK use the axial or refractive map because that's the one when they had their topographer delivered to them, that was the one that was shown to them, which is great, but they don't understand that actually if they're fitting contact lenses, in general, tangential maps are much more useful. And that if you're fitting Ortho-K, you need to be able to look at both types of map because they show you two different things. So the axial refractive map is probably the most commonly used map, and that will give you a corneal surface representation to a single axis, which is normally the axis that falls bang center through the cornea. So it's a very central axis. But that means that every point that is measured on the front surface will fall onto that one axis point. So localized changes and curvatures are poorly represented. But this is great for monitoring and showing central islands post Ortho-K. So, and it's great for showing how good your treatment zone is. If you look at the tangential maps, now these are great. Tangential maps are great for fitting contact lenses generally anyway, and really good for fitting the irregular cornea because it gives you a level of detail that makes fitting those types of cornea much, much easier. So this gives a much better geographical representation because it takes that corneal surface representation and takes it each point of curvature across the whole surface. So it's not going to a single axis. It is taking each point of curvature and giving it its own axis. So it gives you great definition on localized changes, and it gives you much better data in your peripheral than it would on a central axis point. So this will give us the best indication as to how centered our Ortho-K lens is. So we look at the tangential to see how well centered our Ortho-K lens is, and we look at our axial to see how good a treatment zone we have. And let's have a little look and see how that plays out. So we need a tangential subtractive map, which shows our centration. And I have some examples of this to show you. And then we use our refractive or axial, which again identifies the size of this treatment zone and change in refractive power. So let's talk about taking topography before I show you those two different types of maps. Topographers are great and they will take some great images, but we need to make sure that we are doing everything as clinicians to get the best from this piece of equipment. So we need to make sure of the following. Our patients need to have their eyes nice and wide because any kind of eyelids in the way or eyelashes in the way will cause us to get a poor image, which means that the data that the topographer gets from it will give us information that could influence the type of contact lens that we fit, and we may not get the optimum fitting lens. So it's really important that patients' eyes are nice and wide open. There's nothing wrong with getting the patient to move or tilt their head if necessary. We are not all constructed the same way. So sometimes you have patients with very deep set eyes, or they may have a slightly larger nose. So it's okay to not get them to sit straight onto their topographer. And sometimes it's necessary to get them to maybe tilt their head. and don't be afraid to get them to do that. If they have very small palpebral apertures, sometimes it's useful to get the patient to either use their cheekbone or their brow bone to help accentuate and open their eye more. We never do it from the lids because, again, this causes pressure to be transferred to the topography data, which we don't want. But when we use these sorts of extremities, so your cheekbone and the brow bone, that can sometimes help. You need the patient to keep blinking for as long as possible until you are ready to capture the images, because a dry eye produces a poor image, which brings me on to good tear quality. If you have air conditioning, I'm assuming you all have air conditioning in your offices and your clinics. My air conditioning unit was positioned right by the chair, which I thought was a great planning, not by me. So you may find that you need maybe to use artificial tears to help with that tear quality. Good tear quality is really important because most topographers will take the first Purkinje image like a keratometer would. So you need good tear quality. And if you want to use artificial tears, that's perfectly fine. Small drop, give it a few seconds, and then take your images. Don't take just one image. I know lots of practitioners who take one image on their topographer and that's it. No, you need to take several images and then choose the best image from that. And it's always good, if you can, to keep a couple and get rid of any poor images. If you have poor images, just delete them. There's no point in keeping them in your database. You don't need them. They're of no use to you. So make sure you clear down any poor images. So those would be my tips for taking the best topography. So this is just to give you an idea. So again, on the left-hand side, we have an incomplete map. Now that may be maybe because the top lid was in the way or there was some other issue. So we don't have all of the corneal data that we would like on that particular map. That doesn't mean we can't manufacture a lens or create a lens or design a lens from that, but it would be better to have more complete data. If you look at the picture on the right-hand side, hopefully you can see in sort of the inferior section where the rings have become more wobbly, and that's an unstable tear film. And again, that will produce a map or information that could potentially lead to producing a lens that isn't as optimum as we would like it to be. So we need nice, solid, stable rings. Obviously on keratoconic patients, you're not going to get that, but we're talking about a normal cornea here where we're fitting Ortho-K. So that's a couple of examples of what we don't want. So let's talk about how we now fit these lenses and how they're used for Ortho-K. So popular Ortho-K lens designs. I'm sure you've all heard of the CRT lens, which is fitted from a fitting set. It's still useful, and I would still advise you to have topography. In the UK, we have something called iDream by number 7. Then there's the Euclid lens, which is a US-based lens. It's very popular in the Far East. And then we have in the UK, the Menicon Zenite, which is the Menicon lens. And so Euclid, the Menicon Zenite and iDream are all what we would class as system lenses. So you need to have a computer program linked to your topographer. And what that does is it allows for algorithms to design the optimum lens for you and to make changes to that lens. As I said, the CRT is actually a fitting set lens, so you use the fitting set. Okay, so what I want to do now, if I may, is talk a little bit about the Menicon Zenite contact lens specifically. So this is one of our own brands. And effectively, you need your refraction, you need topography, and you need EasyFit, which is our software for calculating the lens. And I think, Josie, I'm not sure whether you've seen the software and how it all works. And I know that we've been talking about these things for a little while, but it's the Menicon Zenite is quite a new generation of Ortho-K. So like most manufacturers, we use precision CNC lathing techniques. But our software is very different to a lot of our competitors in that it ensures simplified fitting. So it will make that first lens calculation for you. But what it also does is it hands back full control to the practitioner when it comes to adjusting the lens or understanding how the lens is fitting and what changes may be necessary to optimize that. We are also a company that is very concerned with making sure that our end user, the patient, is as safe as possible in any device that we manufacture. So the Menicon Z-Night has a couple of additional safety features which are built in. So as I said previously, we're looking for a minimum height or minimum clearance on Ortho-K lenses for it to be successful of about 9 or 10 microns. The Menicon Z-Night is designed to give slightly more clearance than that. It's about 13, 14 microns, which I know doesn't sound very much, but again, this takes into account any interpolation with, that takes into account any interpolation with topographers and ensures that you are never going to touch the front surface of the cornea with the back surface of the contact lens. We also fenestrate the Menicon Z-Night, which means we are reducing the risk of any kind of binding, and it should make removal of the lens much, much easier. And we also manufacture it in the only material that is FDA cleared for overnight wear, which is the Menicon Z material. So these extra precautions or extra safety features, we hope offer additional reassurance to both the patients and practitioners that they are wearing a device that is very safe. So the Menicon Z-Night, this is the construction of it. And we are quite unique in that we don't use curves in the periphery of our contact lenses. The vast majority of Menicon lenses utilize what we call tangent curves, which are effectively straight lines. This is particularly useful for Ortho-K. As we move away from the central cornea, we find that our peripheral rate of flattening, or the rate of flattening, becomes such that you're no longer looking at a curved surface, you're looking at straight lines. And with Ortho-K, where you're fitting slightly larger lenses, this means that it gives us more area for landing the lens, and it also gives us far more control over how we center the lens. And the same is true for our scleral lenses. We use tangents in the periphery because this allows us maximum control over where the lens is landing. It allows us to spread out the weight of the lens and give us more control. So how does that align with EasyFit? So EasyFit is this computer software, as I was talking about earlier, which allows us to take the data from the topographer. It gets imported into this software. It automatically brings in your curvature, so your flat and your steep curves. It automatically works out what your central astigmatism is and what your residual astigmatism may be. All the practitioner has to do is fill in this data, which is the corneal diameter and the full spectacle refraction. And what that will then do, move on, is it will allow us to calculate the lens. Horizontal visible iris diameter is important. We can't assume that everybody is average. So average is about 11.8, and we have to look at those patients who may not be. And if we assume that everybody is 11.8, it would be much easier for us as a manufacturer. We could make one diameter. But the diameter of an Ortho-K lens will influence how well it works. So we need to understand that, you know, you need to take that measurement. Lots of topography machines will allow you to do that, or on your slit lamp, you'll have a graticule. A PD rule will be fine, but we need to have some idea of that from that white to white in order to get the best fitting lens for the patient to optimize the results. So that does need to be put in here. And then that will allow us, once the prescription is in, to calculate the correct lens for the patient. So that will calculate the radius. The spherical component is always going to be plano, the diameter, and then it will also determine the tangent, so that peripheral curve, to land the lens correctly. And it will also work out the amount of height or sag height that we need on that lens in order to get the best correction possible. And here you can see that what we have done is we've got that sag height, which is literally from the back surface or the front surface of the cornea down to where the lens lands. Our tangent is then calculated from that to make sure that we get the best landing zone to give us the most control over centration. As I've already said, we incorporate a little bit more sag height or clearance than our competitors, and this compensates for any topographical errors, and it means that we're reducing any risk of corneal insult. We've got the 3 fenestrations and we've got the material with the highest decay possible. Our particular lens can only be fitted with corneal topography presently. I know we are looking at some other ideas to maybe produce an Ortho K lens that can be fitted from a fitting set. I don't think that this is pertinent to just Menicon Zenite. I think you need good quality topography images are essential for any Ortho K lens that you choose to fit. You need to have really good imagery going in to get really good contact lens parameters coming out the other side. You know, and good topography will lead to a really good success rate. So that's really important. I think topography's got to be good, and you shouldn't be too ambitious with the amount of myopia you want to correct. Assessing fluorescein patterns. Okay, so Ortho K works when you are asleep at night, lying down on your side or your back or wherever with your eyes shut. So when we assess fluorescein, this is to make sure that we have not made any gross errors, and to ensure that we have a lens that is not causing any kind of corneal insult. So ideally, we are looking for this lovely sort of bullseye approach where we have, you know, central clearance, or what looks like central clearance. We have a good band of fluorescein which is sitting in the reverse curve. We should have mid-peripheral clearance, and then good edge clearance. So ideally, in the optimal image, that's what you're looking for. If you have a very steep lens, it will be very obvious because your reverse curve band will be enormous. You may have lots of bubbles. You're going to have probably very little movement on that lens. And we would know that something has gone terribly, terribly wrong. I haven't seen that very often, I have to say, maybe once or twice ever. And on a flat fitting lens, again, you would be looking at a lens that's probably going to be quite displaced, either laterally or superiorly. You're going to have, again, you could potentially have quite a big band in that reverse curve, but you're going to have masses of edge clearance. And again, not very often that we see those. The most common fluorescein images you're going to see are the optimal ones. But again, I wouldn't worry too much if you get an optimal image and it's maybe a little bit displaced, because that's not what the patient is not going to sleep sitting up with their eyes open. They're going to sleep laying down with their eyes closed. And we have to remember that when we look at the lens, we're looking to make sure there is nothing obviously wrong with the fit, because the lens is going to do its magic when the patients are asleep. So how do we apply what we've learned about topography to our Ortho K practice? Well, we know that if we take topography, that's going to give us our baseline, as it would with any contact lens patient being fitted for the first time. It's going to help us to select or determine our first lens, as it would with any other contact lens patient. It will help us to screen out abnormal corneas and poor corneal shape, which may not be apparent if we are just using keratometry. So it's important that we screen out those patients who may have poor corneal shape or a cornea that's just not suitable. It also allows us to fit certain patients cautionary. So patients with maybe a slightly tilted cornea, or if they have strange or abnormal lid architecture, and those patients who have limbus to limbus astigmatism, who can be much trickier to fit and get full correction with. So I think topography gives you a much greater look at that corneal landscape to help you determine which patients are best to fit and how to manage those patients who still insist on being fitted, but maybe are not going to be quite as straightforward. Post-treatment, the topography will let you determine how well centered is this lens? Do I need to change anything with that to improve it? Is my treatment zone size okay? Is my treatment zone good? Am I getting the refractive change or correction that I need? How do I change that if I'm not? So these are all crucial things. You've got your baseline, you've got your post-treatment topography, and you can compare the two and make some informed decisions about how you move forward with making any changes to the lens or not. So these are the topographical responses that we would ideally get. And this is what I was talking about when we talk about differential maps. So these are the things you would typically find when you're fitting Ortho-K. Ideally, every patient you see will have a bull's eye image, which is a beautiful treatment zone and a beautiful ring showing it's really, really well centered. You might get a smiley face, which shows decentration. We'll have a look at that in a moment. A frowny face, which is the same as a frowny face, just upside down. You may end up with central islands or smiley face with false central island. You can see lateral displacement, or you may see a central divot. We're going to have a look at some of the common topographical patterns that you may get from fitting Ortho-K lenses. So this is the bullseye, and this is, I'm going to show you here. So on the left-hand side, at the top image is our baseline, okay? And the one below it is actually a tangential map. So this shows us the sort of centration we would be getting. And when we do a differential map, what we effectively do is we take the data we've taken today, which is at the bottom, from our baseline data at the top, and it creates this image on the right. So this shows a beautiful, beautiful bullseye. You can see you've got that really deep blue area of correction. That's your treatment zone. And just around that, you can see we've got this peripheral area of thickened or pushed out cells. So that is exactly what we want. Now, the only thing that we might need to change is if the patient's still got a bit of over-refraction, that's fine. This can be added to the lens to help improve their vision if they're still not getting the kind of VA that we would expect. The only other thing to look at is if the treatment zone is too small. Again, that's why it's important to look at your where your pupil is, or have pupil recognition if possible, because that could cause flare or other issues with halos, etc. So it may be that they are high myope and you've gone for it to take all of their myopia away, and you may look at reducing your target for refractive error correction to give them a slightly larger zone, or you could look at maybe the back optic zone diameter of the lens, maybe that's a little bit on the small side. But this is an ideal scenario. You may get something like this, which we class as a smiley face. Okay, and again, this is a differential map, so it's taking our baseline at the top there on the left with where we are today, and it creates this differential map. And this particular topographer does have pupil recognition, so you can see the pupil outlined in that black circle. And unfortunately, this smiley face crosses through the pupil margin. So that means that the patient is not going to have optimal vision. They're going to come back and they're going to tell you that their vision is not as good as they would like it to be. You will find more often than not that you're getting some astigmatism come into your over-refraction. And this is normally because the lens is flat fitting. So normally you would steepen or change your alignment curve first, because your alignment curve, as we talked about previously, is the single curve that is going to help you center up this lens really well. So you start with your alignment curve. If you get your centration good and you can improve that, you may find that actually the myopic correction is better, that your astigmatism goes away or is at least reduced. So it's really important that the centration is as good as it can possibly be. Frowny face is just the opposite of smiley face, and rather than being in the inferior portion, it's in the superior and crosses the pupil margin there. But again, you're going to have the same issues as you would with a smiley face. So you're going to have the patient complaining that their vision isn't as good, maybe it's variable, they're getting ghosting, flare, etc. And again, it's a flat fitting lens. So with either smiley or Frowny, it's going to be a flat fitting lens. So we either need to steepen, or we do need to steepen our alignment curve. Again, that allows us to center the lens better. So centration is key when you're dealing with either a frowny face or a smiley face or any kind of lateral displacement. Now this is a central island. So we can see here that we have very clearly in the center of the pupil, we have this raised area still. So there's an area that we haven't quite managed to push those cells out. And that's because we've got too much central clearance. So this is a steep fitting lens. So the patient will complain that they don't see well. You'll have an over-refraction left or no clear endpoint. So we just need to reduce the sag. And then what we do, you either leave it for a little bit longer, and you can leave it for a little bit longer. It depends again on the lens design, and it depends on the amount of refraction you're trying to correct. And the more myopic the patient is, in some instances, the longer that might take. So you either leave it for another few days to see if it resolves. If it doesn't, you do need to then refit with a lens with a smaller sag. So you need to physically reduce the sag height on the lens. Right, okay, so that's the question, and I'm going to try not to let the... So, what are the benefits of fitting Ortho-K over other lens modalities? Well, I think they can be split into two categories. You could say on the one hand, there's the vision correction benefits, and then there's the lifestyle benefits. And again, we are just talking at the moment about Ortho-K generally, okay? So we know that if you fit Ortho-K successfully, the patient is going to get really good vision that should be maintained throughout the whole of the day post-lens removal. So there is no need for them to carry around spectacles, spare contact lenses, etc. So it leaves them completely free of any other vision correction. We know that on average, -4 diopters gives the highest rates of success. We know that we can push that to -450, -5 in a lot of cases and beyond, but you could find your success rate isn't so good. Emerging presbyopes really benefit from Ortho-K because what you can do modified monovision for them really, really easily in Ortho-K. So they sometimes love it because they're not wearing contact lenses. Again, they don't need overreaders. So emerging presbyopes, yeah, a really good candidate for Ortho-K. The other wonderful thing about Ortho-K is it is completely reversible. Unlike refractive surgery, you know, if the patient doesn't like it, they can just stop wearing their lenses and their cornea will revert to its pre-treatment state. So it's a very safe method of correcting refractive error that we know is completely reversible. From a lifestyle point of view, it's really convenient. So patients who are very busy, do sports, some occupations, for patients who have allergies. So patients with dry eye benefit from having Ortho-K. And also during those months where allergies are very high or they have dust related allergies, they're great lenses for those patients. So from a lifestyle point of view, hello?
Hello.
It's very beneficial to those patients. So you need to look at the reasons these patients are wanting to move into Ortho-K. I know that we have some patients that do a lot of water sports, for example, and it's just not convenient for them to have either conventional contact lenses or spectacles because of the risk of the water with contact lenses. So Ortho-K is absolutely ideal for them. But we can't talk about Ortho-K without looking at the risks associated with an overnight wear modality, a contact lens. So from a practitioner point of view, they do require more time to fit. It would be unfair to say otherwise. And you do need additional equipment if you don't already have a topographer. You do need to see the patients more frequently, so maybe on a 6-month basis if this is an adult. We know that poor compliance or non-compliance is a risk with lens care or handling. And that's a really difficult one for us to manage as clinicians, because once the patient leaves our offices, we have no control over what they're doing. So it's something that just needs to be reiterated and talked about, that it is, you know, this is something they have, that the lenses are kept clean, that handling and lens care protocol continues. It's not always possible to get the full amount of correction that the patient is looking for. And that is something to bear in mind. And that's, again, about managing those patient expectations. So it may be the patient is going to be left undercorrected by -0.50 or a diopter, and how we manage that. Now, in some cases, it may not be an issue, and the patient may prefer it that way, depending on the age of the patient. When we look at myopia control or myopia management, full correction isn't always necessary to help stop the progression of myopia. So even a partial correction is useful. And it's also possible that during the process of correcting their refractive error, they're going to need top-up contact lenses. You are not going to take somebody who's -4 to plano on the first night of wear. We would ordinarily look at maybe a correction on the first night of maybe a third of their refractive error, depending on how myopic they are or the refractive error we're trying to correct, and also how malleable their cornea is. So we need to be prepared that we're going to have to, or they need to be prepared that they are going to have to wear something in the interim. And top-up contact lenses are probably the most feasible thing rather than spectacles. So how safe is Ortho-K? Well, very. And I've done lots of reading about the safety of Ortho-K and how safe is it. And actually, it's quite safe. Well, it's very safe. I think the key things that come up time and time again is infectious keratitis. But when you look at the literature and the data that is out there, the most common reasons for patients contracting keratitis is normally either because the practitioner was not as well informed as they could have been, or the lenses weren't fitted correctly, the patient's poor compliance, and that's a key one, and probably the highest reason for contracting keratitis of any kind, or the patients are lost to follow-up, so they don't come back regularly to be seen. Corneal staining is another form of complication with Ortho-K lenses. I would expect to see a small amount of corneal staining maybe after the first night, which should resolve very quickly. But if it's persistent, then it's either because the lens is not fitting as well as we would like it to, or it could be that the patient is sensitive to the solution that we've provided. So I would normally change the solution first, and if the staining continues after sort of 2 or 3 days, I would then maybe look at the fit. But solution sensitivity can cause staining that may make us think that something is not quite right. The other complication that we link with Ortho-K is lens binding. And two of the most common reasons for lenses binding are either that the lens is not fitting well, once again, so it's sort of limpeted on and is difficult to remove, or the lens is dirty. So it's really important, again, that the patient is compliant and that they change their lenses regularly. So Ortho-K is safe, but it's really important to ensure that this is a modality that is safe as possible for your patients, that the lens is fitted correctly, that we educate ourselves and our peers and our patients on the compliance on lens wear, so that they do things correctly, that they ensure that they are handling them and that the lens care is good. We need to make sure we get these patients back for routine aftercare appointments. And I'm not sure how the system works where you guys are. In the UK, it's quite common to have patients on what we would class as care plans. So they pay a fee on a regular basis, and then they can have aftercare intervals, regular intervals, because that's all taken care of in the monthly fee that they pay. I'm not sure how it works for yourselves, but routine aftercare appointments are the key to ensure that we jump on any complications very, very quickly, and that we ensure that they are continuing with the care and handling of their lenses as we have told them. And that leads to very happy patients and a successful ortho-K practice. So this is your question 5. Very briefly, I want to talk a little bit about myopia control. I'm sure that this is something that is in all of your media press, and it's something that is at the forefront, I think, now a lot more than it has ever been for us as practitioners. And we've been talking about myopia control, I believe, now for about 10 years, 11 years, but I think it's becoming more pertinent to practice and the conversations that we are having with our patients. So we know that it is the most common refractive error, and we know that it used to be that we would be looking at refractive errors of -6 or greater being those associated with significant eye disease. But we also know that that's no longer true, and some meta-analysis or detailed analysis actually showed that the same was true for any myopic refractive error from -0.25 up to -6. So we know that there is no real safe level of myopia. So it's not just our high myopes we need to worry about, it's those lower level myopes we also need to look at. And we also know that there are other things that are associated with being myopic. One of them is that the risk of glaucoma increases 2- or 3-fold. I'm sure a lot of you have seen this graph. This is the graph that was created by the Brian Holden Vision Institute. So this was created back in sort of 2010. And at that time, we knew that we had about 28, 29, maybe 30% of the world's population at that time were myopic. And around 4% of those were found to be highly myopic. So they would have been -5 or above. And they have estimated that by 2050, taking into account the growth in the global population, that around half the world's population will be myopic. And 10% of those will be classed as highly myopic. So again, -5 or above. So that's a massive jump, a massive increase from where we were. And this is the reason that we are now all trying to get more involved in myopia control and management, because we are more aware now of the risks that are associated with becoming highly myopic. So you've got your conditions on the left-hand side here and the percentage increase to being myopic. So that's how much more likely you are to have these things if you're a myope. But if we look at this chart here where the risks and those 3 particular conditions, so myopic macular degeneration, I don't know if that's a new term for you guys, but I know that over in sort of Singapore and Malaysia, this is now the leading cause of visual or the loss of vision for a lot of their patients, and it's completely they can't correct it. It's not treatable in any way, shape or form. So at the moment, this is the leading loss of vision out there, with sort of, you're looking at sort of 30–40% of patients that are coming in exhibiting myopic macular degeneration, which is due to myopia that has progressed. And you can see that even at -2, you're 2 times more likely to get MMD. At -8, it's 126 times more likely. We know that retinal detachment is more likely for high myopes. And again, -2, you're still at risk by sort of 3 times more than an emmetrope. and 21 times more at -8. And we also know that cataracts are more likely if you're a myope. And again, the poor -2 doesn't get away with it. He's 2 times more likely than you are if you're plano. So these are the reasons that we are now looking at how we try and stop this young generation. Unfortunately, if you're my age and you're a myope, there's nothing we can do. We can't fix that. You are a myope, you're where you are now, and sorry. So what we're looking at doing is it's the younger generation, it's the next generation of children, the alpha generation. And there are lots and lots of theories. The most common theory as to why a lot of these patients become progressing myopes is due to hyperopic defocus. And hyperopic defocus is produced in the periphery of the retina when we correct a myope with a negative or minus lens, because it pushes that peripheral image past the retina. So it makes the brain think that there's an image being formed outside of the retina and behind it. So what then happens is that the eye stretches. I'd like to say it grows, but I'm not sure it does. I think it just stretches. So it stretches, which is great. It means then that peripheral image is on the retina, but it means your central image, which you need, is now in front of the retina. So you become more myopic and we need to give you a stronger minus lens. And so it goes on to the point where we're in a situation where the eye has stretched past the point of no return, which is why we get retinal detachment and we get this MMD. Now, the way to counteract that is to create myopic defocus in the periphery of the retina. And that happens when we use Ortho-K lenses. So we know that myopia control with orthokeratology is one of the success stories. So we know that it can be managed very well with Ortho-K. There are lots of other things like atropine, which work exceptionally well for both refractive error and also axial elongation, although we don't understand the mechanisms as to why atropine works so well. But we know that Ortho-K works very, very well, as do soft contact lenses, which are created specifically for this purpose, and in some instances, other soft lenses which can be used that are not on label. So we know that Ortho-K works for myopia control, and currently no CE marked or approved Ortho-K lens for myopia control specifically. And this is the reason it works so well. So this is what I was talking about. You can see on this image, we have a negative lens in front of the cornea, and you can see that hyperopic defocus occurring in the periphery of the retina, although we're producing a nice image centrally. So what we need to do is we need to bring that hyperopic defocus back inside that image shell, and we need to create myopic defocus. And what happens is when we create this annulus, hopefully you can see this on the left-hand side of the screen, there's an annulus of red. That's where those cells have been pushed out into the periphery, thickened them. And hopefully you can see on this very small image, I know, I'm sorry, in the periphery of the cornea, you can see that thickening. That causes, it almost creates or behaves like an addition, like it would on a multifocal. And what it does is it causes that image to be brought inside the retina in the periphery and causes this myopic defocus. So there is no trigger for the eye to elongate or grow. So, and interestingly, because we are going to have a quick look at the soft lens options, if you were to put, so this is a retina, or sorry, this is a cornea that has been treated with Ortho-K. So this is the beautiful bullseye that we would expect. You've got that lovely annulus of cells showing that we've created that thickening. If this was a normal cornea and we put a soft multifocal lens, center distance multifocal lens on that eye, the topography image would be very similar. So you would get this sort of annulus, which would show you where the reading addition was. So this is why these defocus lenses and center distance multifocals work so well for myopia control, because Ortho-K does it naturally on the cornea, and these other devices sort of create this peripheral disturbance causing this myopic defocus. So if we look at what's available to us to help treat our patients, we know that fitting them with standard single vision glasses and standard contact lenses has little to no effect at all. You're going to correct the refractive error, but you're not going to assist in reducing or the progression of the myopia. We know that some progressive power lenses and bifocal spectacle lenses have a better chance or a greater impact on myopia progression. And actually it's very good for patients who have some esophoria or accommodative lag issues. And you tend to find that that's quite a close association for myopia progression. So you really need to get that under control if you can. And Ortho-K is great for accommodative lag also. But actually this 55% is linked to one study which was done with the executive bifocal. And I haven't seen it repeated since, but I'm not sure many parents would want to see their children in the executive type bifocal glasses. But, you know, the best three options available to us as clinicians are either a soft center distance multifocal or things like the CooperVision MySight or the Mark-Henry Milo lens. They have been shown to have really good control over myopia progression, Ortho-K or atropine. And if you look at these three things together, they all have approximately the same efficacy, which is about 50%, which I know doesn't sound like a lot, but if somebody was going to become a -8 and they get to be a -4, that's got to be a good thing. You're reducing their risk of becoming or getting MMD or having a detached retina. So we're cutting their odds in half, which has got to be beneficial. So these are some of the soft lenses that also will provide or create that myopic defocus. So there's the Natural View, MySight, Mark-Henry, and there's a new extended depth of focus lens that I believe is going to be launched by Ultravision at some point in the future. So there are soft lenses available as well, where the patients can wear them through the day if it's for myopia control, but the only overnight option really is Ortho-K. Thank you all so very, very much. It was an absolute pleasure once again, and I look forward to maybe working with you again at some point.
Of course, yes, very much, very much.
Thank you. Have a fantastic rest of the evening.
Thank you. You too.
Take care.
Thank you.
Bye-bye. Bye-bye.
Thank you.